Okay, what's the scope of reform? 2 public laws, thousands of pages of statutory language and regulations, many of the regulations still to be written, fundamental changes to health insurance markets and regulatory structures, a very expanded federal role in health insurance, expanded access to care, new delivery models, substantial Medicare, Medicaid payment reductions, new program integrity rules, and all of this will affect all commercial insurers, all medical providers, practitioners, and suppliers, and virtually all employers and legal residents. So, pretty big scope. Now, the stated goals for health care were 5: expanding health care coverage, private health insurance market reform, improved quality, I'm not in Washington. By the way, I'm from Birmingham, not actually Atlanta, but okay. But I'm outside the Beltway these days, so what people inside the Beltway call bending the cost curve, we in the hinterlands just call saving money, and strengthening program integrity. Now, with due apologies to Chris Berman and the ESPN crowd, I'm going to try to do the fastest 20 minutes in healthcare reform. Now, we'll start with expanded health care coverage. What does the bill do? Let's start with who are the uninsured. If you look at the slide, it's a mixed bag. I mean, the first 49% are below 300% of federal poverty level, not eligible for Medicare, Medicaid, and not offered coverage. But interestingly, 30% were eligible for coverage by their employer. 17% had incomes above 300% of the federal poverty level, and 18% were eligible for Medicaid and yet hadn't signed up. 20% were children, and about 20% were undocumented aliens. This obviously doesn't add up to 100 because there's some people that fit in more than one category, but the point to be made is that the uninsured are not a monolithic group. It's a rather diverse group, and there are a number of reasons why they're there. This is a quick map from the census. It just shows you where the uninsured folks are. The darker the color, the more uninsured. Florida, Texas, New Mexico. Perhaps some of that may be due to immigration status, but it is interesting that you see higher rates of uninsurance south, west, perhaps less in the Northeast and the Midwest. Assuming that the law does something about rates of uninsurance, depending on where you are, you may get a sense of more people coming into the system and being able to pay for medical services. All right, how does the law deal with these issues? Let's start with the individual mandate. All U.S. citizens and legal residents are going to be required to have health insurance by 2014. There will be penalties assessed if you do not. And it's fairly complicated, as everything in this bill is. You don't get to 2,000 pages without being a little complicated. And it's a option, not really an option, but either a flat dollar amount up to about $700 annually by 2016, or a percentage of income on the minimum federal, on dollars in excess of minimum federal tax filing requirements. Penalties can be waived if premiums exceed 8% of household income. Income is below minimum federal tax filing requirements, which are about $9,300 for single filers and $18,000 for joint filers, or other religious or financial hardships apply. But that's going to cover most of us. Now, health insurance exchanges, where are you going to get coverage? The bill authorizes states to establish state-administered health insurance exchanges by 2014, through which health insurers may offer small group, and small group for this purpose is defined as 100 and fewer employees, and individual, what are called qualified health plans. And to be a qualified health plan, you have to meet certain requirements. These plans must cover what are called essential health benefits, as defined by Health and Human Services. They must encompass inpatient, outpatient, and other basic medical services, including, and this is important for this group, rehabilitative and habilitative services and devices. These requirements for essential health benefits also apply to small group and individual coverage offered outside of an exchange. So, just your basic small group or individual policy that today you might just purchase directly from an insurer. Continuing with health insurance exchanges. In defining essential health benefits, the Secretary must take into account the health care needs of diverse segments of the population, including women, children, persons with disabilities, and other groups, and may not make coverage decisions, determine reimbursement rates, establish incentive programs, or design benefits in ways that discriminate against individuals because of their age, disability, or expected length of life. I know that one of the top legislative priorities of this group is to ensure that O&P is covered as an essential benefit, and I think those words go a long way toward making that happen. But I think in talking to Tom, obviously the association is being diligent in ensuring that that's going to be the case. Now, plans in an exchange are going to be organized into 4 benefit tiers based on actuarial value, and if you don't know what that means, it's really the total portion of benefit costs paid by the plan. All right, it's basically what's not cost sharing to you. And they're going to range from 60 to 90% plus a special catastrophic plan for persons under 30 who can't otherwise afford coverage. There'll be subsidies, which I'll get to in the next slide, which are going to be tied to the 70% actuarial value plans. The exchanges will be able to offer large group coverage, which is more than 100 employees, beginning in 2017, but that's optional. And federally administered exchanges will be created if states fail to act. And this is important because, as you know, there are a number of states challenging the constitutionality of the Act. And at the same time, state insurance commissioners are at this moment trying to decide whether they should take the preliminary steps to set up an exchange. If you don't like the law and you don't act to set up an exchange and that challenge is lost, it's possible that you may be dealing with a federal exchange. And in my state, Alabama, and neighboring states, I know that the insurance departments are struggling with that question. Oh, I'm hitting the wrong way here, sorry. There we go. All right, premium and cost-sharing subsidies. Income-adjusted premium and cost-sharing subsidies are going to be available to individuals and families who purchase insurance through an exchange, who have incomes between 133% and 400% of federal poverty level. The reason that 133% is the minimum is because those folks will now be eligible for Medicaid and won't be eligible for the exchanges, and who are not eligible for government-sponsored coverage or are offered employer-based coverage with premiums exceeding 9.5 of income or have an actuarial value of less than 60%. Again, this is extremely complex, and employers, whether small employers, are going to have to sort through this, and it's going to be very difficult. Subsidies only apply to coverage purchased through an insurance exchange, and they'll be available in January 2014. All right, employers, the so-called pay-or-play provision. It applies to employers with an average of 50 or more full-time employees on January 1, 2014. There are 2 sets of penalties. First, if you don't offer coverage to your employees. If you do not offer coverage, you're liable to penalties of up to $2,000 annually per full-time employee